So when we look at those patients that are defined with pneumonia, there's, again, this is that idea. The majority of them are going to be bacterial, and then seasonal viruses, other than COVID-19, are going to make up a good proportion. And then you're going to have some fungal, some TB, and some others, and obviously you're going to have some COVID-19. And so we're going to make a determination from this group who's going to need to be hospitalized, and we're going to base that on objective measures of either using a pneumonia severity index or using the CURB decision support tool to kind of go through and look at what the severity, what the age, and other comorbidities are existing to determine who should be hospitalized and who should be allowed to go home, and realizing that the majority of the patients with pneumonia are still going to be able to be treated at home, and that smaller proportion are going to require to be hospitalized. Only the difference here is that because COVID-19 has such a high infectious pattern with it, it's changed our approach with patients who are coming from skilled facilities, because a lot of skilled facilities will not accept a patient back with that diagnosis, and therefore we're having to hospitalize some patients that typically we wouldn't, only because of this infectious control problem, rather than necessarily the usual way of defining it based on the disease severity and that sort of index, those sort of indices or decision supports. So a study that was recently published in Lancet looked at symptom onset to death, and in here we saw that the average was about 17.8 days. The symptom onset to hospital discharge is 24.8 days. And this is really kind of one of the issues that has made it so difficult for pre-planning and modeling this for health resources, was this recognition that when patients are hospitalized, they are hospitalized for a prolonged period of time. And I don't think the lay public understands just how severely different those numbers are in comparison to bacterial pneumonias, right? The average pneumonia patient is hospitalized for 4 days. So when you see 24.8 days, six-fold magnitude greater than the average hospital length of stay, it shows you that even small percentages of these groups can have a large health resource burden in comparison. They still are a smaller piece of the pie, right? And that's why I'm showing this as a pie chart. The COVID-19 is a smaller piece of the pie of everything that a health resource right now is going to have to be mitigated by. But that little piece is creating a much greater burden. And we're seeing that not just in the burden of the hospital length of stay, but the ED length of stay, right? So, and it's affecting all the patients. It's affecting how quickly we can turn around with our dispositions, how quickly we can turn around with our radiology procedures, how quickly we can turn around a number of different processes, just because it just physically takes longer to see a patient, because you have to put on PPE and take it off with those that are suspected of COVID. And there are only so many, ticks on the clock before your shift is over. And so they're being consumed, right, at rates that are less efficient than we were used to acting at before. The all-case fatality rate in China and from the study was 3.67%, which is a high case fatality rate. They adjusted that for demography and under ascertainment. So just as we talked before, that there's probably an under ascertainment of those cases, they made some adjustments for that and still looked at that and saw that the case fatality rate was still pretty high at 1.38%, right? And that's a case fatality rate that's averaged across the population, not under specific age groups. So when you looked at specific age groups, under 60, it was 0.32%. Over greater than or equal to 60 was 6.4%. And greater than or equal to 80 is 13.4%. And so those age categories are an important component of understanding, well, who does this disease affect, right? And it's not that surprising that a severe respiratory disease should affect those that are over 80 far worse than those that are under, right? Because from a physiologic standpoint, the amount of physiologic reserve that you have from your lungs continues to diminish, right? So a simple test of being able to tell the difference is asking somebody to take in a deep breath, right? When you're young, you got to take in a deep breath. There's a long period of where you're just inhaling, where you're just going, right? And when you're older, you lose that reserve capacity. And when you go to take in a deep breath, it's just a quick in, right? So a very odd way to think about this and it's just odd because I don't smoke pot. But if I did smoke pot, the best person to share a joint with would be a bunch of 80-year-olds, because in the end, you're going to get a lot more of that joint than everyone else, because they don't have that reserve capacity, right? So that issue plays out in seeing higher mortality rates here, as well as the issue of morbidities and other aspects that increase that mortality rate. I know it's kind of a strange way to put it, but all right. And then the infection fatality ratio, again, this is going to include those who are asymptomatic, drops down to 0.66%, which when you look at infection fatality ratios, that's a high number. If you try to obfuscate that and make the case fatality rate now 0.66%, you're completely missing the point again, right? So for planning health resources for a country, infection fatality ratio is an important aspect of getting an idea of what the resources and burdens are going to be on those services that service the dead. On those that involve cases, these numbers above are far more informative in understanding what's going to happen and what the duration of care is going to be needed and the resource allocation for treating the living.